fourth International suPAR Symposium was held in late February in 2013 in Aachen, Germany. This year's suPAR Symposium was entitled New Horizons for suPAR, Risk Stratification, Organ Dysfunction and Relevance for Specific Diseases. Almost 100 researchers from all over the world met to discuss the potential use of the prognostic biomarker suPAR. The symposium was hosted by Professor Frank Tacke and Dr. Alexander Koch from Aachen University Hospital.
Good morning, everybody, and thank you all for coming to the fourth suPAR Symposium.
The talk started with insights into suPAR biology and pathology, with a state-of-the-art lecture given by Professor Jochen Reiser from Chicago on the causative effects of suPAR in kidney diseases.
At 2 nanogram, we see an explosion of activation.
The presentation from Reiser when it comes to chronic kidney injury, and indeed the mechanisms behind that we need to look upon if it also relates to acute illness and acute kidney injury.
This was followed by an overview on suPAR in kidney diseases,
was caused by
liver diseases,
that was distinguished prognosis, or
and finally in pulmonary diseases.
And I say I have a suPAR test. suPAR, I can measure and I can predict whether there is.
The overviews were followed by presentations on exciting new data on suPAR in liver cirrhosis. Where does suPAR come from? How is it regulated? What is its prognostic relevance?
And a prolonged QT interval.
New data on the role of suPAR in low-grade inflammation, atherosclerosis and lifestyle diseases were presented and discussed.
It's been done in the Virgates, I think, laboratory.
Risk stratifying a general population and then offering intervention.
And approximately half of the attendees had their blood drawn for suPAR measurement. Within the field of suPAR and sepsis, Chief Physician Jyrki Tenhunen gave an overview on the large amount of data published within the last year.
There are no, targeted treatments to sepsis as activated.
By the end of day one, new data on suPAR and its prognostic value in inflammatory and infectious diseases and sepsis were presented. And the usefulness of suPAR in risk stratification of patients admitted to the emergency department were discussed.
So this is a higher frequency than we see normally.
And trauma is not that different maybe from some of these situations.
On day two, the researchers presented data and discussed how biomarkers may aid in clinical decision-making, in particular in sepsis.
And the field you're touching, like emergency room medicine, might be more attractive for biomarker research. I agree.
Cardiology.
There was a very clear imagination of where a cutoff is going to be.
Kidney failure.
That I presented here are more for
liver failure.
We don't want to treat the patients that will survive anyway.
Example from our daily clinic.
And finally, in cancer.
Gastrointestinal.
The last session gave insight into the use of suPAR as a marker of triaging in the emergency department.
The patient is critically ill or not. But if you just go into Danish...
Katia Donadello closed the symposium with a presentation on the potential use of suPAR in the intensive care unit.
In the complexity of the ICU, it seems that suPAR is able to highlight the severity of the patients that are present in our cohort.
And what was the very highlight?
Well, there are several highlights. I think when you look at the different presentations, some presentations were really excellent because of the data that were new and fresh and showing new insights in how suPAR might affect, for instance, immune system and disease development and so on.
It's been very successful for us, very exciting and interesting and stimulating.
I think it has been really fantastic and amazing experience. There's been a lot of new data and they have really supported that we have a big chance to do something positive with this biomarker.
It's new ideas, new people, new contacts, and that's what these conferences are all about.
And I think the robustness of the data is increasing over the last years, which is excellent. Second, because most of us agree on how we should continue from here. Doing other types of studies, not only epidemiology studies, but also intervention studies. Maybe not only thinking as suPAR as the only biomarker to test, but to look at combination of biomarkers. and looking in different patient groups and having not only mortality as an endpoint. For instance, is suPAR really helping clinicians in the decision they take?
When it comes to mechanisms, hopefully we find something in critical illness as well, find the mechanisms and then have interventions ultimately.
I think that at the end of the 2 days, the ideas are quite pushed forward in order to clearly know what we have, what we need, and what we should do.
I think we can help patients coming to the emergency room in triaging them, finding those who have a high suPAR, maybe get them quickly to the ICU. We see some really nice data in the ICU. We need to quickly start up the antibiotic treatment. On the other hand, we also have seen that those with low suPAR have a very good prognosis. Maybe we can send them home quickly, and so we can use the time and save for those who have a high suPAR.
There is a need to try to combine suPAR with something else in order to make it stronger. That we need to implement the use of suPAR in the emergency department in order to try to better triage patients there.
A lot of new ideas that developed throughout the meeting. Yeah, so I had a great time. It was fantastic having the symposium here, and I enjoyed it very much.
So everybody who sees this, come to Amsterdam next year, I think in February 2014, and we will make you very happy with good scientific presentations and a lot of fun. So see you in Amsterdam in 2014.